just a ton of interest in these webinars. Obviously we're going to be talking about functional nutrition and weight loss. And obviously the topic today is really digging into the GLPs, since it's such a, huge topic nowadays. I will kind of, introduce ourselves and, kind of why we're here today. And then we'll go ahead. Basically how this will work is we're going to spend like 30 minutes today and talking about some important topics. And then at the end, obviously opening it up for Q&A. And then at the end, if people want to stay on, we'll talk more about our Weighless RD platform, which is something we've been working on basically for the last 9 years. And now we're able to launch it and share it with other dietitians and nutritionists. So hopefully we can keep this part to 30 minutes and then hope you find a lot of value in this. But essentially,
Cheri, do you want me to launch the first poll first?
Oh, you didn't launch it yet?
No, I didn't.
Oh, okay. Yeah. Why don't you go ahead and launch the first poll?
Okay. So this one's just getting an understanding or a background of where everyone is at with their experience with GLP, GIP patients. So we're very curious on how many of you have been working with them. Okay, so we have a few people that are brand new to this, but we have a lot that have been involved with GLP patients. Okay, we have all the answers. So great, we have a good group of people to look at a broad range here. So thank you everybody for answering.
At this time, yeah, we really don't know what the needs are of all of you, but this will probably not be ideal for people that are new to it, because we're gonna dig into some details. But again, obviously we're just this is just the beginning of our offerings. So Erica, should I just close this out?
I ended it, so yeah, you can do that.
Okay. All right, awesome. So again, I'm gonna start with the introduction. My name is Cheri Stoka. I am the owner and founder of Weighless MD, which we'll talk a little bit more about. Erica is a functional dietitian and she's our wellness director at Weighless MD. Erica and I have been working together basically for the last 10 years. And functional dietitians really, really super passionate about not only weight loss, but about, the human body. How does the body work? How do we fix imbalances in the body? So our mission really with this platform is to bring dietitians and functional nutritionists together to collaborate and execute strategic weight loss and wellness programs. Dietitians and functional nutritionists are the experts when it comes to not only nutrition, but as it relates to weight loss. And we are just so passionate to be the leaders in driving this really profound change and in this chronic disease and obesity epidemic, or pandemic, I should say. So you do see a QR code there. We'd like to start out with offering, if anybody wants to schedule a one-on-one, they can't say you have to jump off for whatever reason, or you heard us talk before and you're interested in learning more about the platform, you can schedule there. Okay, so just a little bit about Weighless MD. Opened the business in 2015. Right now we have 4 locations. 2 of those are franchises. I did franchise the business 2 years ago. And so we do have other locations. The RD platform is not a franchise. This is completely separate. So Weighless MD is the only medical weight loss clinic owned and founded by a registered dietitian, which is me. So we have, we're able to do so many, just incredible things as it relates to not only holistic, but more of the medical side as well. Our foundation is food. We are all about healthy food, and balance in the body is the foundation. We are a business that does dig deeper into root issues because we do feel like that is obviously paramount in order to get people to not only lose weight, but keep it off. We have spent years and years creating all of our own kind of turnkey programs that are not only super effective, but they're executable. You know, we not only created these for our other franchises, but we have employees. And so our employees, you know, need to be able to execute our programs as well. So everything was always like protocol driven and that type of thing. We have done our own weight loss studies in-house. We've tried many different things. And the programs obviously that work, we keep. And so that's what we'll talk a little bit about towards the end. And we have a team of registered dietitians, functional nutritionists, health coaches, nurse practitioners, and then I do have a collaborating medical director. So what the agenda is for today is we're going to talk a little bit about the mechanism of action of the GLPs. We'll talk a little bit about dosing, who is not a good candidate, how RDs can help reduce side effects, not only reduce, but just manage, because that seems, you know, to be just out there in the media all the time. We'll talk a little bit about diet recommendations, a case study. We'll end it with questions. And then if you choose to stay on for the next 30 minutes, I'm going to go through our Weighless RD platform. All right. So some of you, you know, may already know all of this, but we have really spent a lot of time digging into what the heck these GLPs are. What are these GIPs? What are they doing in the body? You know, I own the business. Anything that I bring and offer to my patients, safety is obviously, you know, the most important, because I say it all the time. I'm like, because the first people in line are going to be my mom and my sisters. So what GLPs are is it's peptides. It's glucagon-like peptides. For those of you, I mean, most people know what peptides are. It's a chain of amino acids. We have over 100 different FDA-approved peptides in our medical system right now. So they are not new to us. Peptides are signaling molecules. They can really be life-changing if used the right way. So basically, what happens when we inject these GLPs into the subcutaneous fat of somebody who's taking it is what it's doing is mimicking what would normally happen if you ate food. So when we consume food, the GLPs are signaled, and then they signal to all different areas in the body to do certain things. So for weight loss, there are three main things that these GLPs are doing to support weight loss. They are decreasing gastric motility. So we hear about that a lot, right? People are feeling fuller for longer periods of time, so they're not eating as much. They also signal to the brain, because we have GLP receptors in the brain, and the brain is one of the main drivers of appetite control. So now people are getting the appetite suppression from this peptide that's being injected. But the main thing that's happening is it's increasing insulin secretion. Okay, when you increase insulin secretion and you start to balance the blood sugars and manage those levels, there are so many benefits that begin to happen. And you can see the image to the right, and that's just, I'm not going to go through all of the different organs and things like that. But what's important to know is that GLPs are absolutely everywhere in the body, and they serve a very, very crucial part of just our whole body chemistry. So when we talk about weight loss, and you think about, well, you know, why do we need this? Why do we need this injection if our body normally does it, right? Well, there's multiple reasons why, you know, food is not doing what it's supposed to do, and the body's not functioning the way that it should. And I think it's, you know, again, this is so obvious, but again, we know that our food is toxic. We know that the majority of people have gut issues. So when you have major gut issues and you have inflammation and you have metabolic dysfunction, the cells are not responding to normal signaling. So what we're doing now with the peptides is we're basically injecting and getting the body to do what it was designed to do, but is no longer doing because of just the state that it's in. So hopefully that makes sense. I'm going to kind of leave it at that because I do many presentations on this, and it warrants a lot of complexities, but I'm going to kind of keep it at that for now. We have the GLPs are hot on the market right now. They're the semaglutide, so it's was Wegovy and Ozempic, okay? And then now they came out with the dual agonists, which is Mounjaro and Zepbound. So those are the dual agonists. So they're GLPs and GIPs. And they're going to be coming out with a triple agonist. And I think that might have even come out already. So these meds, peptides, I keep calling, I have to call it medication, even though it is a peptide. They're going to be around for as long as we are alive. You know, they're not going away anytime soon. So whether we agree with them or not, whether we think, you know, it's the Band-Aid and it's not, we're not getting the patient to do what they were, you know, supposed to do, that type of thing. None of that really matters because it is taken the market by absolute storm. And now we're in a position as experts as we have to know what these are and how to manage our patients. So just to kind of end this part of it, the dual action, so the glucagon insulinotropic polypeptide, which is the GIP, so that would be the other agonist that is in some of the products. So it's just acting on more receptors. And so it's a more kind of robust effect or more robust mechanism of action. So the studies that have been done on the GLPs and the GIPs, so the single versus the dual, studies show that people lose more weight on the dual agonists and they have less side effects. So that's what the studies show. We offer both in our practice, and we've been using semaglutide for way longer, and it's still tirzepatide is relatively new for us, but so far we're seeing that it's pretty similar as far as weight loss and the side effect profile. But again, there's definitely more to come as we get more into it and more experience with it. Okay, so a little bit about dosing because it's really important. At Weighless MD, we work with compounding pharmacies. Okay, so we order the vials and then we draw up the dose for the patient. If patients are getting the GLPs and the GIPs through their doctor, they're getting the pens. So the dose, I was trying to think of the best way to kind of summarize it. I'll first start by saying that it's not about, you know, following that protocol of being on this because it's a titratable medication. So if you follow the guidelines from the pharmaceutical, it's going to be like the first 2 weeks you're at this dose, then you're up at, you know, the next 2 weeks, then you're up and you're bumping up on a regular time frame, a regular schedule. But that is absolutely, I think, the worst way to practice with these types of peptides because the dose is so important. And the goal is to find the lowest dose that is most effective for the patient with minimal side effects. You know, in these types of peptides, insulin, it's the same thing with insulin. You know, if you give too much insulin, the patient's going to do horrible. And, you know, you can't blame the insulin. It's how the person was managed. The person gave, you know, patient too much insulin, so now you have problems. And it's the same thing with these peptides. The dosing is so critical. So when you're working with patients, really kind of getting an understanding of like what dose, where that falls on kind of like the hierarchy. Did they already bump up to the highest? Do they need to go back down? Are the side effects prohibiting them from really moving forward? You know, so there's many things that come with it. And so again, this is something that we're definitely going to dig deeper into in our like mentorship type of webinars and stuff, but it's going to be critical that you have some knowledge as it relates to the dosing. Just a bit about our patients, you know, because again, you kind of hear like, oh, you know, patients are on it for a period of time, they go off and they gain their weight back. Our patients, it varies as far as like how long they stay on it. We have some patients that stay on it for 3 to 6 months, they achieve their goal, they go off of it. We have some patients that literally after the first injection, it completely changed something in their body and they know that they will never go off of it, because GLPs in a chronically inflamed state are shunted. They're not working. So when you give someone a little bit of it, something happens in the body and it immediately changes just different things. And I always just think of this one patient that she comes to my mind all the time. It was like after one injection, like her pain level from lipedema was a 10 at all times, and one injection put her down to a 2 after like 2 weeks. It was crazy. So again, I don't want to get too long-winded with the other ancillary benefits, but just know that every patient is going to be super different, and there isn't like a set like, oh, they need to are on these GLPs, there's absolutely going to be a point where they plateau or they stall. And that has a lot to do with the receptors with GLP, you know, at some point the receptors will get a little saturated. So we have protocols that when patients, we notice that they're doing everything right and they start to plateau, we have different protocols on kind of, you know, getting around those types of situations. Okay, so I am going to now talk about who is not a good candidate. So the hard contraindications for the GLPs and the GIPs are, it is a very specific thyroid. It's a medullary thyroid carcinoma. So it's a very rare type of thyroid cancer. So that's one contraindication. The other one is, I have it written down because I always forget, it's multiple endocrine neoplasia. So it's cancer in your glands. So those are very, very rare. We've never had anyone have that, and we've had to, not allow them to do GLPs, but there's definitely other precautions when we're working with people. And one of the big things is anyone that comes to the table with significant gut issues, which the majority of people now have, that has to be looked at more closely, because we all know that the number one issue with GLPs is GI side effects. So if they already have GI side effects and you put them on this, it usually doesn't get better. Now, we have patients that we will work with them while they're on it and they do fine. Again, it just kind of goes back to like everyone's different. But just note that when you're working with people and they're not doing well, like we have to start digging into like, what could be like some underlying gut issues that could be holding them back. So some of the just diagnosis that we're kind of mindful of too is like pancreatitis, that we're kind of careful. Proceed with caution with pancreatitis. If they have like ongoing like gallbladder attacks, we want to be careful with those types of patients. But other than that, other than those hard contraindications, most people can be good fits for the medication. Someone who also would not be a good fit would be, we don't see this very often, but people are just like under eaters, and that they're not gonna get enough protein during this, especially because they're already not eating enough, and then you start them on this and now they for sure aren't going to be eating enough calories, and then they'll start to muscle waste and then put themselves in a worse metabolic condition. So you want to be mindful of people like that. And then also not only people that are pregnant, obviously you're not putting anyone, or you're not going to see anyone on GLPs that are pregnant, but you want to be mindful of what the medication does while a woman is on birth control, because it actually can inhibit the absorption of a lot of birth control medications. And so some are saying, I don't think any studies have been done, but it can increase your chance of getting pregnant when you're trying to prevent it with birth control. So it's something to just be a little bit mindful of. Okay. I talked a lot there.
We are going to launch the next poll. We'll only do this for like a minute because I want to be mindful of time. So we are already down to about 8 minutes. So I'm curious if you guys want to chime in here and let us know. For patients that you have on these GLPs, you can choose multiples here. Are they successful? Do you think it's the mechanism of the medication? Are they hoping it's the magic bullet? Are they under eating? Yep. Oh, yeah. Okay. So we're seeing a lot of people say they are under eating with this and have negative GI symptoms. The next things we're going to be talking about are how you can help your patients with this. So I'm excited to dive into that topic. Okay.
All right.
I'm going to end this. Yeah, you can move forward.
Okay.
Okay, so we meet with our patients either biweekly or monthly, depending where they're at in their titration of the medication. And we are always assessing their symptoms. So as you can see on the right side here, this is part of our symptom assessment form that's sent out prior to them coming in. And what we're looking for is blood sugar issues. We're looking for hunger or lack of hunger, how their energy is, and the GI tract. So when we see symptoms, most of them would be the GI tract, but a lot of them came in already having GI issues, and this is just exacerbating that. The reason they're having these issues, it's slowing the gastric emptying. So if they've already have dysfunction, it could be causing nausea, vomiting, constipation, diarrhea, all those things to get worse. So I'm going to talk about what we, in the next slide, I'll talk later about what we do diet-wise to help with some of that. Because there's definitely things as dietitians where we can shine here and help. Really just tweaks in the diet can make a big difference. We often see high energy levels, but when they're low, it's usually a good sign that they're not eating enough. And they're typically not eating enough. Either they have too many GI symptoms, like they get nauseous, or they get really full fast and they're not able to even eat enough food. So those are things we watch for. We don't want them under eating. We do have in-body scales, and we look really closely at where they're losing, if it's fat or muscle. And when we see that muscle loss go down at all, we are always focused on, are they eating enough food? Are they getting the protein? Are they getting movement in? We think about hormones. We're looking at that whole picture. We don't get a lot of patients that are actually taking insulin. We have some on, the medications, oral medications, but, there is that risk of low blood sugar. So there needs to be that discussion around how well do you know how to titrate your insulin medications and checking blood sugar more often to make sure that they're not going hypoglycemic. Yeah, I think I covered everything here. Cheri, do you have anything to add?
No, I think that was a good summary. Again, this is just a snapshot. I think, enforcing that it's not just about GI, there's other symptoms that we look at, but obviously this is just highlighting the GI part. Okay, should we move on to the next slide?
Yes.
Okay, cool.
Okay, so every patient is looking for diet understanding in different ways. We have recipes, we have macro meal plans, we also have as you can see here, like a grocery list, a sample thing that they can take with them. And being functional and integratively trained, we know that it's a lot more complex than just a standard way to eat, standard calories, all of that. So we base it off of each individual, their lifestyle, health conditions, motivation. One thing we've noticed that people that are sensitive, they have to modify their diet on the day of injection and maybe up to 2 days later. That's when most of the GI symptoms will occur. So we really hone in on what they're eating on those specific days. We make sure that it's not excessively high in fat because that can further delay emptying. And then some may have to have smaller meals or, cooked vegetables versus raw, that sort of thing. So we definitely look at that first to help them tweak it. It's about balancing the meals, and our recommendations are tweaked based on our overall assessment of their metabolic health. So we have more extensive symptom surveys and intake forms and things where we are assessing that. We also have blood work we do to help assess where their metabolic status actually is. So for example, a lot of our patients have insulin resistance. So we are recommending lower carb, not keto. We know how important carbs are for gut health. So it's reduction and complex carbohydrates and variety. But another thing would be, we're having these patients all of a sudden have all these vegetables. Some of these patients with gut issues, increasing their fiber a ton is not ideal. We have to work on that very slowly as well, and potentially look at supplements to help support them.
All right.
So it's been amazing. We've seen thousands of patients already on these GLPs, and we've tracked the type of results we get. And what we've noticed is after about 12 weeks, the average patient is down 18 pounds, which is 1.5 pounds a week. And the huge piece that we really care about, one of the huge pieces, is the visceral change, that visceral fat, that inflammatory fat. We wanted to make sure that that's also going down. So just after 12 weeks, that goes down by 2 points. Now, we'll talk a little bit more about the InBody scale, but that's how we are measuring the visceral fat. And then after 24 weeks, we see people on average down 31 pounds. So what happens is it's 1.5 pounds a week up to 12. And then from 12 to 24, it averages more like 1 pound per week. And look at the visceral change there, 5 down just in the 24 weeks. Our typical patient, so the ones that do really well on this, and Cheri alluded to it before, those uncontrollable cravings, hunger even after having meals, people with food noise, or even just knowledge deficit. What it seems to do, the medication just helps quiet that all down so that they can then make those better lifestyle changes and learn how to eat long term. Some of the conditions, metabolic dysfunction disorders, of course, the high blood pressure, insulin resistance, diabetes, PCOS, those are a really key piece. Really, these do well for those types of patients. And then we have a lot of the perimenopause, menopausal women that have had that slow weight gain with those hormone changes.
Yeah, one thing I wanted to add to that, Erica, is just the emphasis on the muscle mass and all of everything that's kind of out there that these peptides cause muscle wasting. That is absolutely 100% not true. These peptides actually show to cause muscle synthesis because it's improving the metabolic function of the muscle cell. So when you're hearing and you see people that lose muscle mass, it's because they're not being managed appropriately. They're not eating enough protein, they're not eating enough calories, and so that is the result. We just absolutely don't see that because we're so hyper focused on obviously like the nutrition part.
Cheri, I know you've done so much research on these peptides. We have a question I thought you might just want to answer live. Someone's asking, a very low dose in the benefits in potential Crohn's colitis patients, and your thoughts on that?
Yeah, so there's research. There's not a lot of research. There's more anecdotal going on about the like the microdosing. So I think you said like a small dose. If you're talking microdosing, I think any type of inflammatory condition would benefit from a very low dose GLP. I'm saying that without being privy to any of like the research that is out there. There's a lot of research out there, though you would be surprised how much is out there on GLPs in certain inflammatory conditions. And now for just small dosing and Crohn's, I would be cautious. I probably wouldn't go there with somebody, unless I really had like a good picture of the stability of the patient. But yeah, I would be really cautious about starting someone on it.
We have a bunch of questions coming in. I wonder if should we answer these? Do you want to go forward on the slides? How would you like to
Yeah,
proceed?
let's address two more and then we can move on. If people are okay staying, I mean, I can stay as long as needed.
Sure. Okay. So, do you talk to your patients about the exit strategy? What research has been done on weight management after discontinuing the medication? What do you see regard to this?
Yeah, absolutely. I mean, our big goal is, I mean, that's the number one question that people ask, what happens afterwards? And usually our answer to that is it depends on your metabolic health. So if you come in and you have, 70 pounds to lose and you lose 40 and you still have a lot of metabolic dysfunction and you're still on a statin and you're taking reflux meds and things like that, you're out of balance and the likelihood of gaining that weight back is higher. So it really does depend on where you're at after. But what's very, very important is that they're moving the needle, right? So our goal, and we're kind of looking at all of this. We're not doing like any sophisticated type of testing, but we are looking at the visceral because the visceral fat is the number one driver of inflammation and imbalance in the body. So that we know how to kind of put a plan together for a patient afterwards. So again, I think there was like multiple questions with that, but I think the main thing is that number one, it depends on where the patient is at afterwards. What changes have they made and what are they willing to continue with? And do they have a solid exercise regimen in place? Because if they're not continuously working on maintaining their muscle mass and getting some movement, that weight will come back a lot quicker. But I absolutely don't think that people need to be on it long term, but I do think, staying on it for a longer period of time does help them get to that more healthier state. Hopefully that made sense.
Yeah. How about we move forward to the next slide?
Okay, cool. Okay, so some foundations of weight loss that just dietitians need to know. I feel that, just in collaborating on different levels, I feel like there are some missing pieces. And the big one that we just kind of talked about is not knowing what a patient is losing. If you are working with somebody on weight loss and you don't know what they're losing, you are not helping that patient at all. I think most people understand this. We cannot focus on calories and exercise because the body is out of balance. Metabolic 99% of Americans have some level of metabolic dysfunction. So what that means is the body does not create or use energy as it should. So if you lower someone's calories, the body's going to go after something else. It's not going to touch the visceral because the visceral is not accessible. So it's really understanding that whole process. Not seeing weight as a symptom of dysfunction. Obesity does not cause all of these issues. It doesn't cause heart disease. It doesn't cause what am I thinking? Diabetes, all of them, high blood pressure, high cholesterol. It is a result of all those things. The metabolic dysfunction happened way before the person now becomes in an obese state. So we have to start working on the metabolic dysfunction early on. And I don't think we focus enough on food quality. 80% of our food is ultra processed. It's causing chronic inflammation, chronic disease. So not taking the education a step further and educating people on the SAD diet is so crucial, because they'll be spinning their wheels if they're eating and macros look good and, everything looks on paper good, but it's still heavily processed. It's going to be really hard to get them in that healthier state.